I'm just going to hop over to Facebook to confirm. Give it a few seconds to populate there. There we go. Give everybody just a few minutes to hop in. Oh, yeah, we got people ready. So let's start the show. Let's not keep them waiting. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. And if you are a regular here at the show, you probably noticed that I am not in my usual spot. That's because I am on a family vacation in DR, the Dominican Republic, but still dedicated to you here in my hotel room. You can see it looks a little different. You should see the views that I'm looking at. I see palm trees and beautiful blue water right now, but I don't want to disrupt the show to show you that. I'm going to hold that for myself. But I'm very excited to bring you back the show, and welcome for those that are new. If you are new to the show, my name is Rain Bennett, as I've said, and I will be your host today. I'm a filmmaker and a writer that I've been working with CCF for 10 years. Actually, it's more than that. It's about 12 years now, creating all kinds of video content, live video shows like the one you'll watch today, documentaries, patient-centric, treatment-centric videos, event conference videos, thousands of them probably over those 10 years, but all with the same singular mission in mind, and that is to raise awareness and education about neuroendocrine tumors. That is what we're here to do. Now, the value of this show is really twofold. It is one, the information you're going to get from our guest today, our expert, Luncheon with the Experts, and also the shared experiences and shared stories from the community. I cannot tell you, one thing I have definitively learned in these 10, 12 years is how strong and supportive this net community is. So lean on them. They will help you through this journey. And the first way you can do that is very simple. You can just say hello, introduce yourself, and tell the people where you're signing on from. You can see people are doing that all over immediately. I want to say special shout out. We are now broadcasting these days to YouTube as well, and our YouTube community is growing, so we love to see that. But yeah, go ahead and reach out to everybody, say hello, introduce yourself, and they will help guide you through this. Before we get started, a couple of announcements. One, as we've been saying the past few months, we have now partnered with LACNets to provide a support line and can continue providing support for neuroendocrine tumor patients. So you can reach that or find that support line. You can message us and they will be able to help with that support, or you can go to them directly at lacnets.org/support line. And we also have a very special announcement from LACNets that they would like any of you to join them in person for a very rare opportunity to gather at the National Cancer Institute in Bethesda, Maryland, for a joint patient educational event between the NCI, LACNets, and our friends at the TheoPara Alliance. So that's going to be a very exciting thing. Hey, listen, let's give it up, first of all, for in-person events again. I love the shows that we do here and the what technology allows us to do, but at times it's really good to connect with people in real life again. And so all NET patients and caregivers are welcome. The conference will not be live streamed or recorded, so you'll have to be there, breakfast and lunch provided, and information about the hotel link and travel and all of that is on the LACNets website. So go ahead and book by August 15th. Another announcement, personal announcement, just a shout out to my wife for taking care of the kids right now so that I can conduct this show with you all. She's out there, braving that and, spending time in the pool, but still for a couple of hours, making sure the kids are behaved. If you're a parent, it can be challenging. Finally, we'd like to thank Ipsen Biopharmaceuticals for their support of the series. We couldn't do the show without them, but we do have this disclaimer from them, and that is that the opinions expressed by the guest presenter today, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation today. So this is really the crux of it. Audience members should not rely solely on the opinions or information expressed by the guest today and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. That's really the point that I want you to hear We're going to give you some good answers to your question, good general advice, but by no means do I know your specific case, and most likely our guest doesn't either. So take that advice, take those answers to your question back to your home team, which does know your specific case, and make the best plan and path forward for you. Okay, I am done. I would like to introduce our guest, Dr. Dan Halperin. How are you, Dr. Halperin?
Just great, Rain. It's good to be with you again after a few years of hiatus.
Absolutely. It's been a while, but that's a testament to the show, which is still running strong, and people are asking for, we're doing it less frequently now. And I see comments every episode about how they want to go back to weekly. So that's a good sign. It means we're helping people. For those who aren't familiar with you, tell us a little bit about yourself, where you work, and as I like to say, the role that you fill in this neuroendocrine tumor community that I alluded to earlier.
Oh goodness.
In your own words.
Yeah, no, I think I probably a pretty small role in the overall community, but so I'm a medical oncologist at MD Anderson. I've been here a little more than a decade now, actually, probably around 12, 13 years. So we've been in the field, I think, the same amount of time, and really, primarily sort of focused on. Um, how we help our patients with systemic therapy and decision making, and have been fairly active, I think, in terms of clinical trials. A bunch of cool stuff going on right now, but really, this is what I've done and all I've done for quite some time, and it's really, as you say, it's just such a pleasure to be part of this community. It's a really warm, sort of welcoming environment. I'd say both on the patient side and also on the doctor and provider side as well. And so I'm just glad to be with you all.
Absolutely. Thank you so much. As I said earlier, I've been a part of the disease, and, from a kind of tangential perspective. So I've learned a lot. I've seen a lot I've seen so much in those 12 years, Dr. Halperin. But there's a lot of activity. It seems like there's a flurry of activity going on right now, in a good way, right? A lot is being developed, a lot is being studied. What are some of the things currently that you are either one excited about that are coming down the pipeline, as they say, or things that you're hopeful for that you would maybe like to see more of or more focus on, I guess?
Yeah, that's a wonderful two-part question. Um, I think so. The stuff that we're really interested in right now, and I think what I've personally been investing a lot of time and energy in within our program is really sort of how we can leverage somatostatin receptors optimally and somatostatin receptor directed therapy.
Mhm.
It always sort of strikes me that we've been trying to hit the same receptor for going on like 40 years now, and yet we
Yeah.
keep learning more. Um, and I think both the radiotherapy side of things, right? How do we optimize the radiotherapy? What's the next generation look like? And what are the combinatorics? Should we be mixing radiotherapy with other things? And some things have worked out, and some things are still in process, and some things we're going to learn a lot more about over the coming years. But there's a ton of, and then sorry, and just one more thing, and then some of even the preclinical stuff and some of the clinical stuff that hasn't worked out as well as we would hope, in terms of now that we've got the receptor locked down, what are we delivering? What's our payload? Not just radioactivity,
Right.
but also non-radioactive things that we can deliver. So there's a lot of so to speak action, I think, there, really building on the successes of lutetium PRRT. I think the area that is sort of outside of the spotlight in within our field, and I think of interest to patients and investigators alike, and that is probably the number one source of questions in my clinic, other than somatostatin receptor directed therapy, is probably the immunotherapy space.
Right.
Right, it might be the number one most commonly asked question. I think so far we've been sorely disappointed, and I think uh, there's a lot more to learn there. I think we have more homework to do. I don't think we have the targets as well defined
Mhm.
as we do with the good old somatostatin receptor, but but I think that's an area that hopefully we'll be able to invest more time and energy and money in, to sort of get us up in the morning while the somatostatin receptor directed things let us go to sleep at night.
Got it. Yeah, appreciate that. I think that helped kind of set the stage a lot. But we do get a lot of the questions, as you alluded to, about those things that are coming up right now. So I'm sure we'll get some today. Lots of questions are already pouring in, so I don't want to selfishly take up any more time. I'm going to go ahead and pivot to them. Before I do, I just want to say a special shout out to Monica. It seems is the first timer from YouTube from Brazil. So hello, Monica. Welcome. Again, I love to see now that we are opened up to YouTube the amount of people that are joining us. First question is coming in from Skip. Skip says, "Do you see a future of histotripsy for NETs?"
I'm going to have to plead ignorance on the very first question and say that I'm not actually familiar with that technique. So that doesn't mean there's no future. It just means I can't see it from where I sit.
Understood. Hey, and this is a good opportunity for me to mention this to everybody, but specifically to you, Skip. If we hit moments like that, or if you have follow-up questions, like there is no limit to how many questions you can ask, and sometimes we will have to ask you for a little bit more clarity or exactly what you mean. So feel free to chime back in, and hopefully we can get the answer to your question. But appreciate you being here.
I will say that while you were making that excellent point, Rain, I did take the time to consult with Dr. Google to at least familiarize
My favorite
myself
doctor.
with very effective for consultations at whenever you need them. And so just to kind of to read directly from Dr. Google and then offer some color commentary. This is essentially, it sounds like a high frequency ultrasound local ablative therapy.
Mm-hmm.
And so my general perspective on ablative therapies as a family
Mm-hmm.
is that there often is a role under carefully selected circumstances for local ablative therapy. Usually when you have a local problem that you're trying to fix. I think the bar in terms of where we need to be in terms of evidence to think about these things as helping people live longer, better lives is generally fairly high for me. But I think in general, that's the way I think of that family of therapies, and always happy to see data that it might be helping our patients.
Understood. Thank you, and thanks for your question, Skip. From Judy, and this next question comes from Judy. This is a big question. I think it's still worth talking about, even if we can't necessarily answer it, but that's your job, not mine. Judy says, on average, how long does lanreotide keep NETs at bay?
Oh, okay.
Right.
So yeah, no, go ahead, Rain. Excuse me.
No. I just, I know that you can't just be like, oh, blank,
Well, so this is one of my favorite topics, actually.
Great.
But not in the way you think. So, I'm gonna answer this in two parts.
All right.
So, it's easy to pick up the New England Journal of Medicine article on the Clarinet study and look at the medians and say, look, here's how the population of patients did who was on best supportive care. It was about a year and a half before the cancer grew with nothing, and then we think it's a few years, right, on the lanreotide, right? But although there were some issues with estimating it in that trial. But here's the thing, right? So those midpoint numbers apply to the specific population of patients studied in that specific trial, and in fact are going to be in part a product of the mixture of people who went on, right? We can't forget that particularly that study, Clarinet, very efficiently done study in patients with well-differentiated somatostatin receptor expressing gastroneuropancreatic neuroendocrine tumors. But in fact, if you know that the cadence and the pace of the disease is different, if the Ki67 is 8% versus 1%, and if the primary site is in the stomach versus the pancreas versus the small bowel, then you know that the ratios of those patients are going to contribute to the numbers that you pull out, right? And therefore, how you extrapolate from that and apply to an individual human being sitting in front of you is somewhere between difficult and impossible. So the way I would prefer to frame it is that we do have strong evidence that this is a therapy that slows the rate of growth of the disease in the population of patients that was studied. And typically it will hold things stable for a period of months or years. But I think, the crystal ball is usually broken, and sort of predicting what it'll do for a specific person is really challenging out of the gate. So long answer to a short question, but that issue of sort of the heterogeneous composition of patient populations and how it influences the way we can interpret the data, I think it's really, really critical, because you can't just pluck that median number out of the air and feel like you know the answer, because you actually don't.
Well, this is a bigger point that you're making too, that I hear all the time, of like, numbers don't lie, right? And it's like, yeah, but they do tell a story,
Mm-hmm.
and you have to dissect what that narrative is
Exactly.
and what's the other perspective you can look at all the time. I mean, so I think it's a great answer to the question, but also a great, bigger, larger point that you're making there, of like, yeah, data, it's still layered, right? It's not just that black and white. But thank you, and I appreciate your question. Let's move on to the next one. Jim says, what can you share, if anything, in regards to research and developments in scan and treatment options for patients without somatostatin receptors?
Ooh, that's a really difficult question. And what I would say, okay, so breaking that apart a little bit. So scan wise, I think we're fairly early in terms of alternatives. I don't think there's anything sort of in certainly in the standard of care domain. I think there's a lot of experimental targets for imaging that people are working on, some of which have been around for quite some time and not really yielded high quality clinical evidence yet. So I'd say let's kind of stay tuned to our preclinical imaging friends and see sort of if and when that happens. I think the question is really valid and important. What are we doing when we don't see somatostatin receptor expression? And I think the reality is not enough. I wish that were different. There certainly has been sort of continued development on sort of the tyrosine kinase inhibitor family and sort of combinations and things. Studies like Cabinet come to mind, the cabozantinib study that Jen Chan is leading. But I have to admit, with all of the enthusiasm and energy that's being poured into the somatostatin receptor, that's energy that's not being poured into folks whose cancer doesn't show us a good target. And I think that that's an area where we really need to keep pushing. Frankly, it's a great question. Ask that to the NCI if you don't mind. Wouldn't mind a couple more bucks in that direction.
Good point. Appreciate that. Next question. This is an interesting question. It's also broad. Robert says, my tumors keep growing, but I am active and I have no symptoms. Is it safe to delay treatment until the tumors bother me?
What a great question.
Right.
This is the $1 million question. So with the preface, I'm just going to remind everyone of Rain's intro, right? Obviously, I wouldn't be providing specific advice for a specific person about what is or is not safe in their specific situation. In general, though, one of the core questions of our field is, when is progression really progression, right? And what I would say is, in an ideal world, like the ideal time to intervene is right before it bothers you. Not at the time the cancer is bothering you,
right.
Not day one when it's not going to bother you for years, but whenever that point comes, when you think it's around the corner and you have good reason to think that it's coming, that's really when you'd love to be changing things up. In practice, I would say, that's why our clinic visits tend to be a little longer than some other folks, because you're really trying to get a sense of what the trajectory is over time, what, if anything, is threatened. Because I don't want you to be suffering with your cancer, right? The idea is we want to stave that off. So let's do something before then, but also not expose you to an undue sort of period of toxicity when it's not going to bother you. So that is a really tough judgment call. But I wouldn't necessarily wait all the way until the time when it's bothering you. But I also wouldn't say if you're miles away from there, you need to be jumping all over it and doing more harm than good. I think that's the balance we're all doing our level best to strike.
Got it. Appreciate that. And thanks for your question, Robert. It was indeed a $1 million question, as Dr. Halperin said. Let's see. Next question from Diane. Diane is recently diagnosed with peritoneal nets, which spread to the liver. Just for some information, well differentiated, grade 1, Ki 67 at 1. Just started octreotide monthly injections. Will this help? I also read that peritoneal nets cannot be the primary site, but that is what I'm being told. So any help or guidance would be appreciated. So two questions in there.
Yeah. So what I would say is this. So taking the second part first, I do generally think of the peritoneum as a site where the cancer goes rather than where it comes from. That being said, I've done this long enough that I know I don't know everything, and I think we do occasionally get surprises. I think as I often have to counsel my patients, you can't always find the primary site, no matter how hard you look. And fortunately, patients in that group, we tend to sort of lump in with the folks who have small bowel or endocrine tumors. That tends to be sort of the where these things can hide, and tends to approximate how well people will do in that situation. So broadly, I agree with the skepticism and a careful evaluation. You might not always get any more than that. In terms of whether somatostatin analogs help, I think the evidence suggests that broadly they'll slow the rate of growth of the cancer. I would say in any completed study that evaluated patients with well-differentiated neuroendocrine tumors, that was the top-line result. Obviously, it's a little bit difficult saying, well, if the peritoneum is the primary site and that is true, then have any of those patients been in any of those studies? That's probably not. But I would say it sounds like a very reasonable sort of guideline concordant and evidence concordant approach out of the gate to sort of do as much good and as little harm as possible. Again, in general, not sort of for anyone in particular.
Certainly. Well, thank you for that, and I appreciate your question. And if this is your first time, Diane, welcome to the show. I'm glad you found us. Dr. Halperin, I told you before the show, I like kind of these big fundamental questions. I think I have one for us. Megan says, can you explain what the term metastatic means in terms of nets?
Yes. So metastasis refers to the cancer moving from one place in the body to a separate compartment. So that can be either a totally separate organ, right? So the classic scenario being the tumor coming from the small bowel or the pancreas that then shows up in the liver or the peritoneum. Those are considered separate spaces. Under some circumstances, it means a distant lymph node, right? Such as a bowel tumor that shows up in one of the lymph nodes up here above your clavicle. I still struggle actually with what's the first lymph node that counts as metastatic? Is it the one next to the aorta? Is it the next one up? That one is too difficult for me. I just know it's one that is difficult to get out. But broadly speaking, metastasis means it's spread to another space.
Got it. Thank you. Appreciate it, Megan. Next question from Linda. Two questions, three indeed. Let's see which one. One is about what exciting neuroendocrine research or clinical trials are you working on right now? The second is, and I'm interested in this one because I see this often, is, are there any new treatments being used in Europe that are not currently offered in the US, which I know traditionally or historically that has been the case. We'll take those two first.
Yeah, I think it depends on sort of which side of the fence you're thinking about. So in the clinic, we have a number of really interesting studies that are going on right now, and we're excitedly waiting for results from that or two, right? Asking about the role of upfront PRRT for patients with more aggressive neuroendocrine tumors. There's also, of course, Compose that compares a novel adotatalk PRRT against chemotherapy and other things for patients with more aggressive cancers, and then very excited about the Raise Bioactinium study that has just sort of opened up, and we're starting to see folks on that trial. And that I think is more about people who've had prior PRRT and then progress later after achieving some control. Is there benefit to treating with a round of alpha against whatever else we might pick? And then, of course, for frontline folks, we are interested in the age-old question of is more somatostatin receptor engagement better, which the Sorrento trial elegantly asks, actually, which with a compound that increases the systemic exposure. So finally, I'm looking forward to having that debate settled, because it's been as long as we've been here, that is more better has been a question we've struggled with. I think that if you want to sort of hop more preclinically, I mean, there's some stuff that's still cooking, trying to understand the immune environment that we're hopeful something will shake loose one of these days, and then we are actually working with Professor Alcerini across the street, changing out the payload for chemical conjugates. So, for example, can you deliver temozolomide via the somatostatin receptor and get higher doses into the cells? Obviously, that's in the lab. That's not in people. So, like I said, it depends sort of which side of the street you're interested in. But there's a lot of cool stuff that's going on both in the clinic and that we're working to bring in. Can you remind me of the second question, Ray?
The second is just are there any new treatments being used in Europe that aren't currently available here in the States?
I would say I would say that not in sort of routine clinical practice, like there was that long-standing discrepancy around lutetium PRRT in particular, and of course there's sort of multiple generations of agents and so forth. But I don't believe there's kind of that kind of, continental drift. Yeah, exactly. Yeah. That huge gulf like there was for all that time. I'm sure there's creative stuff going on both sides of the Atlantic, and everyone's working to develop new treatments, but nothing quite like that.
Yeah, I think now it's that they offer more rounds of PRRT in some countries. At least I've heard from the patients here on the show.
They always have. I mean, that's
okay.
I still remember. I mean, we have friends from across the Atlantic who very much challenge the notion of the standardized regimen that we use of lutetium and whether it's appropriate in either direction. Should we do more? Should we do less? But that I think is in sort of the shades of gray.
Yeah, I get that. I think the real question that Linda here was driving to was, is there any current treatment for GI nets beyond PRRT? And my assumption is she is here in the States.
I mean, I think in the experimental space, so I mean, I would say there's a number of studies that are looking in that space specifically, right? So if memory serves correctly, the cabozantinib study, I believe, is open to folks who have received prior PRRT. As I mentioned, that the alpha, the actinium study, and then for folks who don't have access to clinical trials but did have access to PRRT, there are some folks who are giving additional cycles based on the European retreatment data. I think Vanderswan was probably wrote the largest series, but that's very much sort of it's always better, I think, to be on the cutting edge than to just retreat and cross your fingers. But those are sort of the things that we tend to think about in that space.
Got it. Thank you. Hey, thanks for all your questions, Linda. Next question from our friend in Brazil, Monica. My tumor is located in my stomach. My doc says there is no chemo for it, only after the operation to remove the spot with cancer and then chemo. And I had an endoscopy last month. thoughts on that? I think she's just just needing some guidance or perspective.
Yeah, I mean, it would be hard to comment specifically. I think,
Yeah, for
um,
sure.
I think generally for localized, well-differentiated neuroendocrine tumors, we do tend to think of curative intent operations as being sort of a rational step, and we tend to think of true systemic chemotherapy, that targets rapidly dividing cells, as being sort of less favorable for
Hmm.
most. Um, we have to know the rules and when to break them. And obviously, the exception is pancreatic neuroendocrine tumors, as folks are aware. Um, but I think beyond that, that setup would be a little bit difficult for me to comment on, unless it's sort of some other flavor of neuroendocrine neoplasm or something.
Understood. Appreciate that. This is a good question from Grace, who I forget where you're from, Grace. I remember you being here last show. Welcome back. But remind me, if you could, what would you recommend for stage 4, grade 1 cancer female patient in regards to reproduction? Get pregnant and carry the baby on octreotide, stop octreotide, avoid conception completely and use a surrogate. I know this is like we've never had this question, I don't think, before, so I know it's a big one, but
So this is a really tricky and personal question, is the honest answer.
that's fair.
Um,
Yes.
and I think probably the most important thing I've learned is that you can never guess exactly, how someone's values are going to guide them through these sorts of decisions. Um, what I will say is, um, historically, my understanding from endocrinologists, who are 10 times smarter than oncologists, by the way, um, is that the first trimester in particular with somatostatin analogs, I think there may be some challenges there. I think later trimesters, um, meaning the third, you typically, I believe, things get a little bit safer, and there's published evidence on that. Um, but it's a very, the decision, and we've gone through this with people, the decision of if and when you hold treatment, and for how long, around this very understandable deep-seated desire to have kids. I mean, it's just such a personal judgment decision, and I think the most important thing to do is just have a really honest conversation about the risks and what you're willing to tolerate, and how you most want to proceed, because it's delicate. We've worked our way through it for a number of folks over the years, but it's a really personal decision.
Totally. Well, thank you for answering that with such care. I know it was a sensitive one, but it's one of those, kind of, I mentioned before we started, that I bet often people have, that maybe aren't as vulnerable and transparent as Grace was to ask it. So I appreciate you fielding that. Next question comes from Jean. Jean says, what are the major factors used to determine whether tumors are operable or not?
Oh, great question. So I'm not a surgeon. I actually don't. I'm not obligated to make the decision of whether the cancer actually comes out or not. And I do usually have to phone a friend in close call situations. I think the most important question is, what are you trying to achieve, right? So in all of our treatment decisions, we need to know what our goals are, and then we can sort of work back from there to figure out what techniques we should be using, right? And so, as I'm sure we're everyone is aware, um, curative intent surgeries are generally for local regional disease, right? And so we tend to think about making it go away and never coming back, right? Tumor in one place, it comes out, cross your fingers, do some scans, and never hear from it again, and just have a friendly visit with your surgeon or oncologist regularly to do some scans, and talk about life, and offer some reassurance. I think that when you're talking about, as I said, I can never quite tell where that lymph node is. That means it's truly out of the box. Still working on that one. Maybe I'll know one day. Once you're talking about distant disease, right, or more advanced nodal and metastatic disease, large surgical series say that the recurrence rate is 99%. And to me, that says that other 1% is people who just, didn't come back for whatever reason, right? 99 is not something we tend to see. So, so if it's not a curative intent intervention, then the question is, what is the benefit, right? Are you preventing a complication? Are you addressing something acute? Are you reducing the hormone burden? What's your goal? And then if once you know what the goal is, if it's longer, better life, the highest quality evidence is generally with systemic therapy, right? We actually don't have randomized evidence for surgery. That doesn't mean you shouldn't do it. It just means know what you're trying to do, articulate the risks, articulate the benefits, articulate the goals, and then make an informed decision. But don't just cut because you can. The real question is whether you should.
Got it. Thank you. Okay, next question from Fred. Can a person live with a very slow growing probable lung net, 8 years, 1.3 centimeters, without any symptoms and not opting in for any biopsy or treatment?
Anything's possible. I've seen a lot of things in my life, but yeah, I think that globally speaking, a pattern that emerges from the data in different settings is that tumors under 2 centimeters can frequently be exquisitely lazy. And I believe, in the pancreas, we have data about sub 1 centimeter tumors that in a memorial series, 0% of them ever went anywhere. And we know from sort of, MEN databases, although that's another sort of group of patients entirely, that growth rates can be extremely low. Rectal neuroendocrine tumors, very small, smaller data sets, but also sort of under 1.5 centimeters, 2 centimeters, they can be extremely indolent. So, would that surprise me to hear that from someone, that they had a sub 2 centimeter tumor pretty much anywhere that wasn't going anywhere? No, that wouldn't surprise me. It wouldn't surprise me at all.
And also, Fred had a second question that was, are there any specific cell characteristics exhibited by a lung net when viewed on a low-dose CT scan without contrast?
Not that I'm smart enough to tell you about.
Thanks, Fred. Appreciate your questions, as always. Next one comes from Judy. Are CT scans safe to get every 6 months?
How I wish there were, absolute black and white answers in this life. Much like other things, it's about the ratio of risks and benefits, right? So, generally speaking, for most people who have, say, a metastatic cancer, we tend to think of the risk of the CAT scan as less than the risk of the metastatic cancer, and even as they accumulate over people's lives. In some centers, folks are able to calculate what your radiation dose and exposure and risk is, sort of on the back end. I've heard of people doing that, but generally speaking, has it been done for many, many, many years without ill consequences in plenty of people? Sure. Does that mean there's zero risk? No, I wish there were something in this life with zero risk. But generally speaking, that's the balance we try to strike.
Got it. Okay, next one comes from Donald. Donald says, when I flush, it's not just my head and neck. It includes my head, neck, arms, legs, chest. So that's concerning. The question is, should I be looking at something more than carcinoid syndrome or other than?
Hard to answer a specific question. I think, have I seen patients with carcinoid syndrome who have, dramatic flushing beyond their head and neck? Absolutely. Does that mean you absolutely should not interrogate other potential causes, and I can exonerate everything else that I'm not smart enough to know about?
No, of course not.
I can't quite attest to that either.
Yeah, I think that was probably that was helpful, at least for me. Donald, let us know if there's more, but just is that common, because we know that's not the most common areas where it presents.
But we certainly see, I think, truncal stuff and extremities. It happens.
Yeah, both fair points that you've made. So hopefully that helps, Donald. But do let us know if you have any other follow-up questions. This is a common one from Erica. I have a recent small metastasis, but my doc has recommended wait and see, 3 millimeters in my lung. I know others are in the same boat. The question is, why? Why wait?
Yeah, it is a really good question. The reason is this. As we alluded to, actually, I think in the first or second question, right, Rain, about like, can I sit on this? Should I wait until I'm symptomatic? Should I not?
Yes. Yeah.
I think for many of us, who see patients over many, many years live with this disease, a couple of things emerge. One is, and we really don't want to expose you to toxicity you don't need, especially when we can't articulate a benefit that exposing you to that toxicity will buy you. And what I would just point to is, as an example, if we look at the randomized studies of, say, somatostatin analogs, right, we know that the progression-free survival improves with the medicine. But when people cross over from the supportive care arm to the active therapy arm, they actually catch up in terms of overall survival, leading many of us to conclude that whether you start now or start later, you're going to do just as well overall. So why rush into therapy? It's not free, and there's nothing with absolutely zero side effects for absolutely 100% of people, right? So if we can't say that doing it now is definitely going to help you, it often justifies waiting. And as Josh Mailman likes to say, it's not watch and wait, it's watch and learn. And the cancer teaches you a lot when you do that. I think the other thing just to point out is that lung metastases are actually exquisitely uncommon for many patients with neuroendocrine tumors. And I certainly find in my practice that when I see something that's really small in someone's lung, my first inclination is I'm not convinced that's a neuroendocrine tumor. And especially if it's so small that you can't get a needle into it, the only thing you can do is wait and see what happens, and think about whether to biopsy it when it is big enough that you can get it. So what I would say is there's actually a number of reasons to kind of sit on your hands in that situation, and not expose someone to undue risk and toxicity.
Got it. Hey, thanks, Erica, for your question. I hope that helps explain. I know that's probably an uncomfortable position. I get it. From Sheila says, are there new options that have come out or are coming out for large liver tumors that have been noted as non-removable?
What I would say is that, I can't really speak to the local therapy landscape of any new technologies or approaches. I will admit that as I alluded to earlier, I tend to bucket local therapies and local regional therapies together, mainly because I'm not smart enough to tell the difference. I think on the systemic therapy front, there's a number of, as I said, there's a number of things that are in the pipeline. I think the reality is, if we knew that any of them worked and were just around the corner, then there wouldn't be a clinical trial. It would be standard of care. So that's probably how I'd be thinking about it. Is local stuff we have and we'll keep refining, and distant stuff, or systemic stuff, I should say, is sort of in that clinical trial realm.
Got it. Folks, we have about 15 more minutes with Dr. Halperin, and great questions so far today. Keep them up. We're going to try to get to as many of them as we can. Next one comes from Crystal. Crystal says, I have stage 4 neuroendocrine cancer. My question is, can these tumors be painful? My oncologist seems to think that my tumor was found on accident, but I was in pain for 5 years before they found it, which sadly is a common occurrence. But what do you think about Crystal's questions, Dr. Halperin?
Yeah, I mean, so the first answer, there's two parts to that question, right? So can these tumors be painful? They definitely can. I mean, depending on the zip code and the location and what they're next to and what they're pressing on. There are a number of scenarios in which one can deduce that the tumor is making someone uncomfortable, and some of those are extraordinarily difficult to deal with, and there aren't always good answers. But that does not necessarily mean that everyone's tumor is painful and does not necessarily mean that the tumor is always causing pain. It depends on that sort of context, right? Um, so in some regard, I know it's an unsatisfying answer, right? It's maybe, right? It kind of depends on a lot of details that we're not privy to. But usually, if the doctors are looking at the films with the radiologist, they can usually tell if it's in a zip code that would be likely to be causing symptoms, and sort of help with the best approach from there. I've certainly seen a lot of variability. I do think, Rain, you hit on just one thing there with the 5 year lead in. Is it okay if we digress around that for just a moment?
Absolutely, 100%.
So, because this is a point that comes up a lot, and um, I think it's worth sort of recognizing a really difficult position that we put our patients in medicine, which is that the structure and philosophy and teaching of medicine and the way that we are taught to approach problems from like day one of medical school is to start from the stuff that kills people immediately and the stuff that's really common and sort of work our way down from there, doing increasingly complicated testing with greater risk and greater toxicity and greater cost, instead of just doing everything all the time in everyone, and exposing people to lots of radiation and lots of cost, and sort of work our way down a cone, right? And so what that means is that when you deal with a disease that tends to be rather indolent and also tends to be rather rare, it's not going to be one of the first things that's seen and identified. And so what it means, if you kind of step back and look at that, is that practicing medicine in the way that we believe to be appropriate leads to a situation that systematically erodes the patient's trust. And it's incredibly uncomfortable, right? It's really unsettling for a lot of the people who I meet with. And it's kind of it's like a feature, not a bug, as they say. That's kind of people are doing all the right things and it takes forever. And it's really unsettling for people. But I think it's important, because it's really easy for someone to sit in my seat as the Monday morning quarterback and be like, 5 years, that's ridiculous. Everybody I see has this story, which is true, right? Just we heard it right, that right. It's always and in fact, right. That doesn't mean someone was wrong. It doesn't mean someone didn't have your best interest at heart. It doesn't mean they're a bad doctor or they're going to take bad care of you. It means they're actually, doing all the right things. And it's just that's our thinking as sort of a larger medical community, and we shouldn't, we shouldn't degrade our opinions of the folks looking after us for doing the right thing. So sorry for the soapbox. I feel like
No. I respect you standing up for your people. And in this scenario, I think I'm the Monday morning quarterback.
we all are, but that's okay.
Yeah. No, I appreciate you mentioning that. Thank you. We have two questions that are similar. Kind of one is more vague and one is more specific. I'm just going to ask them. They come from two different people, rather. Kathy says, do you see a lot of secondary cancers that come from neuroendocrine cancer? And if so, which are the most common? And then Bridget says, is there a greater chance of getting a regular cancer, i.e. stomach cancer, when you have NETs in the stomach? So that one's a little more specific, but it's generally the same question, the potential affiliation of NETs with other cancers.
Yeah. We could take those questions in a number of directions, to be honest. I actually think that there are some data. Julie Hallett up in Canada had some epidemiology data about second primary cancers sort of broadly being found more frequently in patients with neuroendocrine tumors. And I do believe in some subset of patients being a greater concern, actually a greater threat to life and limb, if you will. It's always difficult to tease out how much is stuff that you found because you were looking really closely, because you were monitoring someone,
That's a good point.
versus a true sort of risk association, where there's some underlying factor. The second direction you could take that in is to say, are there genetic syndromes where things run together? The answer is very uncommonly. Um, Typically, very, very clear family histories under those circumstances, most frequently patients with pancreatic neuroendocrine tumors, but a little bit in the foregut, the lung, and the thymus as well, but really pancreas. And even then, it's a very small subset where we think about that. And again, usually pretty clear family history. The final question, though, stomach, is interesting because stomach in particular is a zone where neuroendocrine tumors show up because of underlying field defects um, the vast majority of the time. So recall that the majority of gastric neuroendocrine tumors arise in the setting of an elevated gastrin. Either, I like to think of it as either a physiologically elevated gastrin, because the person has atrophic gastritis, can't make enough acid, the body tries to make you make more acid, and then that gastrin causes little tumors to proliferate, and so there will be often a carpet of neuroendocrine tumors, all tiny, all non-threatening, along the stomach. So in that regard, right, well, you have a lot of neuroendocrine tumors. And then occasionally folks with Ehlers-Danlos syndrome, right, where they have a tumor elsewhere that is making gastrin, very, very different presentation, but those folks will also then have a carpet of neuroendocrine tumors, but their stomach is very acidic, right, and they have ulcers and perforations and things like that. And then there's a tiny proportion of people, relatively, who will have what we historically call a type 3, or I like to say a eugastronemic neuroendocrine tumor, right, the gastrin level is normal, and I just think of that like a neuroendocrine tumor anywhere else. So what I would say is those are infrequently associated with other types of cancers. Doesn't mean I've never seen it, but it's not like there's some common association there other than that sort of gastrin-mediated field effect leading to more neuroendocrine tumors. So a very, very, I don't know if that was intentionally or unintentionally nuanced question, but a lot of different ways you can answer it. Great, all great topics though.
Absolutely. Just shy of 10 minutes left, folks. We're going to keep moving while we have Dr. Halperin. So Pam says, I'm reading about NETs. I'll assume from Dr. Google, which Dr. Halperin also referenced today. I read that only 1 in 5 people with treatment that the NETs will actually shrink. Is that true? I know that treatment can cause them not to grow bigger, but how reasonable is it to expect or hope that they actually shrink?
Is the part where I say it depends. Then the answer is it depends on what.
We're going to hold you to whatever your answer
No,
is.
It's subtler than that. So it depends on both the actual cancer and the actual therapy, right? So if we restrict ourselves to well-differentiated neuroendocrine tumors, pancreatic neuroendocrine tumors historically tend to be more likely to shrink with most therapies, right? So as an example, I tend to think of somatostatin analogs as having a roughly 2% response rate. That's in the literature somewhere from 30 years ago. And every patient I've ever seen who falls in that 2% has a pancreatic primary. Similarly, whenever we look at, for example, phase 2 studies where we look at patients with both pancreatic and extrapancreatic primaries, the response rate is basically universally higher in the pancreas cohort. The same thing is true in therapies that we use every day, right, like chemotherapy with capecitabine and temozolomide, where you're going to see best available evidence would say a 30-ish to 40% response rate in patients with well-differentiated pancreatic neuroendocrine tumors. But as John Strasberg and Tamaya recently published, Tamaya Altuba at Moffitt, well-differentiated small bowel grade 1-2, 0% response rate, right? So a wide gulf between the two. And then, of course, there's PRRT, where we have to be a little bit careful. This is probably where I'm going to guess Dr. Google got her data about 1 in 5, because the response rate in NETTER-1 for patients with mid-gut neuroendocrine tumors was, depending on which data cut you saw, 17 plus or minus 2%, right? So that's about 1 in 5, certainly on that 20% high end. But pancreatic NET patients in retrospective series had about double the response rate, is probably the best way I would say it. The small bowel response rate in the Tessa Bravander 2017 CCR paper was like 30% in midgut, so probably an overestimate, and pancreas was about double that at 50 to 60. So, and then of course that doesn't even get into what are the response rates in lung with various therapies. It's really difficult to say because we have very limited data. So the answer is it depends. Particularly for pancreas, there are some therapies we use to achieve a greater chance for shrinkage when it's what we need. It's just sometimes at a bit of a toxicity cost. For patients with small bowel tumors, the road is often tougher, and we usually have a harder time making them shrink. With systemic therapies, for like a local bulky tumor causing a local bulky problem, their regional therapies can be effective, which is what drives us to use those therapies under those specific circumstances.
Got it. Thank you. Time for a few more. From Samantha, for pancreatic nets, should you also have an endocrinologist along with your oncologist?
I think it depends. I think if there are endocrine issues that the oncologist is having a difficult time managing, then it's very reasonable. I don't necessarily think that it is mandatory out of the gate. I frequently phone my endocrine friends for my insulinoma patients in particular, because I'm always terrified of a low blood sugar causing someone trouble, and want to make sure that we're doing our absolute best by them, and we sort of come to a plan collaboratively. But that's a really small subset. And most folks, not necessarily, unless there's a specific issue needing attention. At least in our center. Other places might be different, I should say.
Next question from Carlos. What do you recommend for lowering lanreotide side effects during the week that follows infusion?
It depends on a few things. So what I will say is somatostatin analogs, as a class, they have slightly different blood chemistries, but it's not uncommon for us to see the first couple of injections for our patients. They'll have some GI distress in particular. And we do tend to think of that as being pancreatic suppression. Remember, in clarinet, 5% of the people supposedly have the side effect of pancreatic insufficiency, and another 20% had diarrhea. And a lot of the time, supplementing pancreatic enzymes will actually help with those other 20%, at least in our practice. Oftentimes, that's just about getting to steady state. And after 3 to 6 injections, the blood levels tend to be fairly stable instead of going up and down, and people tend to feel the same throughout the cycle, and don't necessarily have worse side effects in that week. If it's a persistent issue and folks have a hard time, then it's always reasonable to talk about whether the dose is appropriate for your body or whether you should be on a lower one. Together with the oncologist delivering the therapy. Those are probably the two most common maneuvers: wait and lower the dose, and supplement the pancreatic enzymes. Those are probably my 3 favorite maneuvers in the clinic, but it depends a lot on the individual circumstances.
Got it. Thank you. Maybe time for one more. Brianna says, would surgery to remove a well-differentiated tumor when there are others that are not operable, would that be beneficial at all?
Rain, I'm going to say it depends. So there are, again, leaning on Dr. Hallett's data, particularly for small bowel tumors where people can get into local trouble with obstruction and other things. There are data that you can reduce downstream complications. We tend to be in our group a little bit selective about trying to not intervene needlessly, but also try to prevent suffering where we can. So what I'd say is there are circumstances under which it's very reasonable. And then there are some circumstances where the risk benefit doesn't make sense, right? Either because the risks are too high or the benefits are too opaque or unclear. So we can't say for everyone, but is it the sort of thing that sometimes makes sense to do? Sure, there are circumstances under which we push in that direction. Again, I'm not the one who has to cut, which is good for both the patients and for me.
Absolutely. Well, folks, that is our hour. We are done with the show for today, but I want to thank you so much, Dr. Halperin. I appreciate you being here very, very much. We're seeing a lot of great comments from how well you answered the questions in like simple terms for people to understand. I personally loved a lot of the metaphors and analogies that you used, and I appreciate your time very much.
Thanks very much for having me. It's great to be with you all.
Absolutely. And folks, thanks for you as well. As always, we hope this program helped answer some of your questions. I know we didn't get to them all. We never do because there's so many good ones, but that keeps the show going on. I do want to say, though, if you have follow-up questions, you can always reach out to us at carcinoid.org, also at lacnets.org. Now that we are partnered with them to provide that support line to you, shout out to our friends at LACNets, and also a reminder about their awesome event they have coming up with the patient, joint patient educational event with the NCI, the National Cancer Institute in Bethesda, Maryland, as well as FIO Para Alliance. Learn more at lacnets.org, but that's going to be an awesome event. And listen, always big thanks to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, I am your host, Rain Bennett, signing off. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.